which is our revenue and capital budgets. And I anticipate this not taking too long because we've had a special meeting about it last week. So this is not a subject that we're unfamiliar with collectively or individually as a board. So Robert.
Thank you, Chair. And yes, there's two parts here really to pick up. One is the revenue side, and the second is the capital part. They are both coming for approval to Trust Board, although noting, as I'll go through, revenue is slightly it's a position that's not quite resolved as yet. It's work in progress. I'll pick up the revenue first, and then just run through capital after that. So in terms of revenue, what you have here is a position which is work in progress. This is all largely driven by the fact that the National Planning Guidance has been delayed, as we are aware. And we have a variety of elements to that planning submission that we need to put in, one of which is clearly the revenue budgets. So what we have here is a summary of all the work we've been doing since the autumn, and has been through both Finance Performance Committee as well as, Chair, as you drew out, we had a briefing last week. The bottom line position at the moment is that the gap we have between the income that we expect to receive and the expenditure that we need to spend to deliver our services, as set out in the paper, was 3.8 million. So we had an initial gap of around about 8.2 million, which we need to resolve through a variety of different forms of efficiency programme. What I just draw your attention to is section 9 of the report, which covers the key elements of that efficiency programme and the work in progress that we are going through. That's page 116 of Diligent for a couple of pages. So those are the key elements. What I can report in terms of an update to this report, actually today is the formal submission day of the draft plans to the regional and national teams. At the moment, where we are is a 2.7 million deficit, which we are still working through. Those elements set out there around cost control, income and efficiency. I think the part I would just draw out formally here is the last part, which is the least palatable part, which is the how do you balance things when you've done the other elements. That is the bit that we will need to work through, and there are likely to be some difficult decisions for the board in terms of how we balance our requirements to deliver core services against delivering appropriate quality of care, delivery of operational performance, and achieving our financial duties. So that is all still very much work in progress. I think you're all aware that the finances are particularly difficult for our system, and we are feeding into that discussion. So the final part to say on revenue then is what you'll have gathered from the paper is that in terms of Trust Board approval of the budgets are sound budgets. What we need to do is we need to close out efficiency gaps. So in terms of planning perspective and us going into the fresh financial year, we are seeking to effectively set those budgets. The bit that we haven't resolved as yet is how we completely close that gap out, and that's something we will need to resolve as a trust over the next 3 to 4 weeks. I'll just quickly skip to capital, Chair, and then take questions if that's okay. In terms of the capital position, that's a little bit more straightforward. We know what our capital allocation is, and the paper sets out the process we've gone through internally to prioritise that against a variety of schemes, both digital and on the, if I can say, bricks and mortar side of things. We've actually got quite a significant programme of work, and as we'll discuss later, we have a more significant programme of works because we've got an EPR replacement, which Lisa will obviously talk to us about later. The capital budgets are slightly overcommitted at the moment, which is actually what we're asked to do and is normal it's about 67k. That's something that we just draw together for the final submission. That's fairly straightforward to do, but the capital budgets are as set out, and I'm not anticipating any other changes to those. So that's it, Chair. That's the summary of what we've got here, and I'm clearly available to take comments.
Okay. Anybody? Any comments or questions, Sue?
Two questions. One is about the removing the over-established headcount. So what the timescale for that would be, and whether people would expect to be redeployed in a manoeuvre like that. And the second is what we put in for contingency.
Yeah, so the over-establishment actually is something that we've been working on as a trust for probably about 4 months actively now. It actually relates almost exclusively to our starting well 0 to 19 service, and it's where we had non-recurrent funding over 3 financial years, but effectively 2 years funding to boost capacity on the back of COVID, so COVID recovery. A number of those roles were taken on recurrently, and the funding is now not available, and we need to resolve that. We've been working to that as an exec team. It is something we need to do as soon as possible. We would anticipate that we would be seeking to redeploy staff, yes. The contingency element, yeah, that it's a good question. It's difficult. I suspect where we will be, Sue, is the same place we were for 23-24, which was around, we don't actually have recurrent contingency reserves anymore. We used to in a few years ago, but that's not something we've had. We will be seeking to create a little bit of headroom, if possible, through the use of non-recurrent slippage or other windfall opportunities in the plan. At the moment, those look pretty thin, but that's what we're trying to do. The key message is we're trying to get the budgets as right as possible, and then obviously working with all our colleagues across the trust to try and stay within budget. So that's where we are.
Thanks, Robert. So if we just stay with Sue, did you wish to come back?
Yeah, just on that, when there is a gap in a vacancy, presumably one budgets for the role, but if it's gapped, does that create a contingency?
Stu, you're getting really into some nuts and bolts here for me, which yeah, actually we budget for fully established through the year. There is a practice that the trusts kind of head to. Sometimes they put in what's called a casual vacancy factor, where they assume there's a bit of a benefit. It clearly just reduces your headroom in year. It's not somewhere where I'm particularly keen to go. We did used to have some of that. We did manage to write it out a few years ago, but it is something that is quite widely deployed amongst a number of trusts. But essentially, one way or another, you've just got less flexibility and headroom in there. But it is something that's used, casual vacancy factor.
Okay, any other questions? We obviously had our session to ask the questions. Robert, could you be quite clear about what you're asking us on the revenue budget side to agree today? And could you also articulate how we will, from a governance perspective, finally agree the final budget, which would mean that how we've closed that gap and our agreement to closing the gap? So 2 bits there. What are we agreeing today, and how are we going to deal with what we haven't agreed?
Yeah, fab. So actually within this report and behind this, we have a full set of revenue budgets agreed for the organisation, or proposed for the organisation. Those are what we're seeking to agree. That allows us to set the budgets for the budget holders. Essentially, that would at the moment create a 2.7 million gap, which would be sitting within our central financing reserves. That's the bit that we need to work through in the next 3 or 4 weeks as to how we close that out. In terms of governance, the final submission to the national team is the 2nd of May. I think we're anticipating on the back of the submission today that there's likely to be a process through the next few weeks, which takes us through April, of some sort of reporting into the regional team on a periodic basis. What I'd anticipate is once we know exactly where those dates are, we will need to have some sort of mechanism to update board around that. Now, if you remember last year, we did that through a couple of different means. One, we did it through sort of weekly briefings that Sarah was sending out as by way of updates, and then I did a fairly formal and comprehensive run through where we got to, and then we'll close the loop on that formally at the May Trust Board mark. So from a governance perspective, that's how I'd anticipate it working.
Okay, thank you very much. And it's worth making the point that I know board knows, but for minutes, is that the delay in all this is nothing to do with our finance team, Robert, Denise and the team. It's to do with the lack of information from elsewhere, notably operational planning guidance coming out very much later than it normally does. It's normally Robert's Christmas present on Christmas Eve. It certainly didn't come through until I think at the end of Feb or beginning of March. It wasn't long ago, and there is some other information outside of the trust which hasn't come to Robert and the team yet. So I just wish to make that point publicly, that we're in this position, nothing to do with our internal team, that have been. It's created greater difficulties actually than normal for our team, and thanks to the team for doing that. So can we agree the revenue budget as set out and explained by Robert, as set out in the paper? Okay, that's all nodded and approved. Similarly, can we agree the capital budget as set out in the paper and explained by Robert? Yes, so they're both approved. Thank you, Robert. Thank you, Denise. Thank you to the team that goes behind it. I do know there's a huge amount of work goes into it in some difficult circumstances, and being in a challenged integrated care system as well really doesn't help when there are some large deficits kicking around. So thank you very much indeed. Okay, moving on again, yourself, Robert, item 17, which is the performance management framework.
Yes, and I can be very brief on this one. This is a core governance document we use. I think board will be very familiar with it, and it sets out the mechanisms and processes that we use to ensure that we're delivering operational metrics that we need to, and if the circumstances where we're not, actually how we go about addressing that. It's been through Finance and Performance Committee, and as I said, is quite an established document. So it's really just an update for this year for the changes that we need to make. Clearly, there's some key cross-referencing to how we're restructuring integrated governance within the improvement plan. But other than that, I just bring it for approval.
Okay, standard paper yearly basis. Can we approve the performance management framework as set out? Served us well in the past, we'll do so again in the future. Okay, all approved. Thank you very much, Robert. Quality account priorities, Natalie.
Thanks, Mark. So this is the annual setting of our quality priority accounts. It's been through Quality and Safety Committee, who initially scoped out a range of suggested priorities and have proposed the following 4. So bear with me, my system's going really slow. So we are putting forward for board's approval 4 priorities that very much align with the work that we're already doing in relation to the improvement plan. So the first is around looking at staff feedback and making sure that we are looking at the improvement plan through the eyes and lens of our staff feedback. The rationale for that's very clear in relation to one of the new quality statements from the CQC that closely aligns staff feedback and effective staffing to the quality and safety of care that's delivered directly to patients. So there's a clear correlation between those 2 factors. The second is the implementation of the Patient Safety Incident Response Framework, PSIRF, which again closely aligns us to us becoming or improving ourselves as a learning culture, picking up some key themes from across the organisation and doing lots of thematic learning, but making sure that we're learning across the whole organisation. The third is the testing of care opinions and the potential rollout of care opinions, and really ensuring that we're getting that really high quality patient feedback of how they feel about services and able to explain their stories to us. And the final one is about the improvement of the risk assessment and risk management work, specifically related to mental health. This relates to the re-evaluation of whether we continue to use the GRIS tool and a more robust training package offer for staff. The outcomes are represented in the paper as well, so how we'll know whether we're successful in those account priorities, and asking board to sign those off today.
You're on mute, Mark.
That's only the fourth time today, so I'm having a bad day with that today. As a segue, mentioning QNS, and the chair of QNS wants to offer a comment or ask a question. Janet.
Yeah, thank you. I didn't want to ask a question. I just wanted to say that we discussed this at Quality and Safety, and I think we were of the view that actually this was absolutely the right list, that our quality account priorities should actually be closely aligned to our trust priorities, and what we're actually doing. And I'd like to say that I thought this was a very good paper, a very good list, and in particular the actual how we would evaluate progress, putting it in at this stage, so that we know how we're going to measure it before we start. I know that sounds a bit radical, is a way of ensuring, or hopefully ensuring, that we do this successfully, and actually when we come to produce the quality account, that we're setting ourselves up to succeed. So I wanted to endorse these, and also to thank Natalie and her team, in particular Tori, for putting in all the work to do this, because I think they've done a really good job.
Thank you, Janet. If there's nobody else, this paper and this list or set of objectives in the quality account does feel different this year. And I think it's got staff and it's got patients right in the very centre of it, which is exactly as we should be. It somehow feels more real, not to criticise past quality accounts, but this feels more real, and is our core business. So congratulations, as Janet said. Can we all agree those then, please? All agreed. Thank you very much. Thanks, Natalie and the team. Like Janet says, especially Tori, as ever, there's always people behind the scenes that deliver these things. So thank you very much indeed. Okay, takes us on to our standard performance reports, which we'll move down through the list. So the first one is back to Janet, John, Natalie, whoever's going to take this one.
Okay, thank you, Mark. I'll start and just pull some bits out of the report, and then hand over to Natalie. And I think John may want to say something as well, but I'll just briefly go through the report from the committee. Some of these things we've noted before. For example, the improvement plan. We had a long discussion about this, and really did interrogate Scott. And pleased to say that he managed to produce the answers, which gave us assurance. And we also looked in more detail at the CQC must-dos and the action plan around those, so that we could be assured that actually we were going to deliver those. Picking out, we did look again at the statement of purpose for the trust, which we thought was a really useful document, and would be useful for new NEDs and for new employees. It really demonstrated the range of services that we provide as an organisation, and also the locations that we provide them from. And I think it gave us all pause for thought, really, about the size and scope of the organisation that we're working in. Other items we've already touched on. Matthew's referred to the risk summit around Droitwich, Ombersley and the rurals. So just to say that we noted that, and we'll get reports on that. And we reported 2 emerging quality concerns. One about measles, which you'll know is a national issue, and we were assured that the trust had a plan in place around that, should there be any outbreaks. At the time of the committee, there were none. I'm assuming there are still none. Natalie's shaking her head. That's good. We also heard about an emerging risk or emerging quality concern around pre-employment checks in the medical directorate. and had a report on that. And I do wonder if John may want to say something at the end of this report, just to update everybody on that. Other items I wanted to pick out, we've talked about quality account priorities. The summary quality report, we looked at the assurance levels. You can see those there. And I'll ask Natalie if she wants to say anything about that. We had various other reports, ones I wanted to pick out. Medicines Management 6-monthly report. We assured that at a level 2, but I think I wanted to assure the board that actually there have been a lot of issues identified within Medicines Management. We've had a relatively new appointment as the lead there, and I think a number of issues have been identified, but we do have an action plan to actually address those, and we're hoping that, we're anticipating with our next report that we will have a higher level of assurance. The lockdown mitigation update. Lockdown in all our heads, I think, is linked with COVID. This isn't a COVID lockdown. This is around should there be need to lock down any of our premises. I think we reported to a previous meeting that we were looking at an action plan to mitigate the risk, and that came to the committee with timescales. And it's given level 3. It's currently on track. Other items I wanted to pick out in particular were around the positive and proactive care and the sexual safety and mental inpatient wards. That's been highlighted in the CQC report earlier, to say that the committee, this was identified a fair while ago, I would say probably about 12 months ago, and there was a benchmarking exercise undertaken. We had a report back in June, which updated us, and this report was to update us further. The appendix that came with that report actually was an earlier benchmarking exercise, the one at the beginning, so we were unable to get assurance at that meeting, but since then Natalie has submitted an up-to-date benchmarking, and it shows that we've got partial assurance, and a lot of the actions to bring us to fuller assurance are due in May, so we will be having a report through to our June meeting of QNS, so that we can get further assurance there. So I think that's all I wanted to pick out here. I just want to give John the opportunity to talk a bit more about the pre-employment checks, and then Natalie to pick anything out of the quality report.
John, from your perspective, board has been kept aware of the pre-employment checks. Is there an update as to where we are now?
Yes, so further notifications have been made, and we are now progressing through the recovery plan, and we are in the process of getting the DBS checks done as soon as possible, but also have been expediting the occupational health clearances with the Worcester Acute Hospital Trust as well. So good progress is being made on those aspects. And what we are doing in the meantime is also doing an undertaking with the people who are waiting for the DBS and occupational health checks, just as an extra safeguard, which has been recommended to us by NHS England. So yes, and I will provide a further weekly update this Friday as well in terms of progress.
Thank you, John. Was there anything you needed to add, Natalie, to that quite comprehensive report from Janet?
Just a quick update on the safeguarding risk that was cropped up earlier. Sorry, I had to leave the meeting for a few minutes. A comprehensive summary otherwise, Janet, so nothing else for me to pick up. In the safeguarding report, in the quality report, there was no concerns flagged during the report, but I highlighted an emerging concern that we since added to the risk register around our ability to attend strategy meetings due to temporary funding ceasing at the end of March, and there's 2.4 registered nurses and 0.5 admin staff that are dedicated purely to attend strategy meetings on behalf of the health system. We are currently still working with the ICB, primary care and the local authority to see if we can find any resolution and solution to ensure that health are as best represented at strategy meetings as possible. I don't have a solution today. We have another meeting at the end of today today, but just to reassure board that I am working through that in detail and trying to find as satisfactory resolution as possible. It will mean that we are having to take some quite difficult decisions about work that our safeguarding team will have to stand down if we're unable to secure any funding that are non-statutory duties, but still add a lot to the health economy and the safeguarding arena. But we have to prioritise strategy meetings.
Thank you, Natalie. I think another symptom of the financial environment the sort of public sector finds itself in. Could I ask, Natalie, you bring forward to Q&S whatever your mitigations or otherwise are for just some examination there, I think would be useful. Okay, if there's no other questions, can we all note the report as brought forward by our executives and Janet, please? Thank you very much. And then move on to the Workforce Committee report. Tessa?
Thank you, Chair. I'm going to assume that everyone has read the report as such. There were just a few things I just wanted to highlight that maybe haven't been reflected in this. We had quite a significant conversation at the Workforce Committee regarding HR systems and processes, and particularly around the procedures for hearing allegations and complaints and investigations, and a big piece of work is being done to look at that, and I know Vina's very keen to get underneath that and find out what's going on and how we can make our systems and processes more effective and efficient, as well as the medical workforce emerging issue that has already been covered in quality and safety. We also talked about the emerging risk around freedom to speak up and the speed of getting freedom to speak up known by our staff group so that they use it, and the response to those issues that are raised, and how the organisation make sure that people's expectations are managed effectively. And that's being looked at by Natasha, our Freedom to Speak Up Guardian, and assessed as to whether there is actually a risk that needs managing, particularly around the reputation of Freedom to Speak Up. And then if you don't mind, Chair, I'd just like to say that for transition from me going at the end of the month and Vina taking over, I've worked very closely with Vina and Elaine over the last probably 6 months to make sure that all the issues that we talk about formally and informally are picked up and embedded. A couple of issues came up at the Workforce Committee that will be on future agendas, including workforce planning, and making sure that we also get back to having an ICS update, because pressure on the workforce agenda had made that slip off, but that will now be back in the work plan. Also to say that my health and wellbeing non-exec director lead role has been passed to Carol, and Carol and I met with Kate Lees, our staff wellbeing lead, last week or the week before. The days have begun to merge a little bit, and Kate and Carol have got a list of issues and things that they're going to carry forward, and I have fed those issues back to Elaine as well, so that she cited on the things that need to be linked in and tied into the work that's being done. And I think other than that, I'll pass to Elaine to talk about any specific issues.
Elaine, is there anything you wish to raise outside of what Tessa's covered?
They're contained in the integrated workforce report, Mark. To an earlier point made around the complexities of some of the workforce challenges that we're facing, about increasing the quality of appraisal, the more effective management of sickness and absence, responding to staff concerns around ability to retire and return, but also flexible working are probably the ones of particular note. But they are part and parcel of our improvement plan and the shift in our culture to be more inclusive and compassionate. So unless there are any specific questions, I'm happy to take those.
Okay, thank you. I'll go through the order. Or Tessa, did you wish to come back specifically on what Elaine said before I go to the others, or no? Okay, Robert, Sue, then Tessa. So Robert first, please.
Yeah, mine was just a point of accuracy, and it's probably important for the just noting that in the workforce committee report, it says there were no reports for information and no reports for governance. Actually, we just need to look at this report, this summary report for next trust board, because it's not actually an accurate representation of what went to committee.
Yeah.
Okay, thank you, Robert. And yeah, we must get that right. Sue.
May I just pick up on a point which is on 250 in Diligent, that there have been an increased number of investigations into people looking at families and friends care note records, and just bearing in mind what's going on in the national media at the moment. Presumably that is a risk if those investigations are finding that people are doing that. So are these investigations revealing that is happening?
Not that I'm aware of, and I don't know if that's anything that Jill's team has picked up, because it would be, they're accessing that through Ulysses, but
I can pick that up, Elaine, if that helps. Yeah. So we've seen a rising trend. We've had a flurry of investigations that have been commissioned where the allegation is people have accessed care records that they weren't entitled to. Those are currently open. So we don't know the findings yet. However, we've taken action immediately and communicated out through teams for team meetings to remind people that unless you are clinically should be on that record from an admin or a clinical perspective, not to enter anybody's clinical records.
Veena, did you wish to speak about that particular item? I thought you may. Yes. I'll go to Veena. Apologies, Tessa. We'll come to you when we finish this specific question. Veena.
Thank you. I wonder whether it would be helpful for us to clarify how we badge that in terms of seriousness, in terms of the disciplinary sanction, possibly, if it gets to that. Is that do we regard that as gross misconduct or something lower? What's the trust position on that, Natalie?
It would depend, Veena, on the circumstance. So it would absolutely deal with each individual allegation, and it would then be the appropriate level of severity depending on the circumstances.
Okay.
It could be gross misconduct. It might not be gross misconduct. So it would absolutely depend on.
I think Jill and Robert wanted to perhaps comment, because I saw the hands go up quickly. So if we go in the order they came up for this item, so if we go to Robert and then Jill on this, please.
Yeah, just Jill may add, but just in terms of mechanisms and assurance around this, and actually to your specific question, Veena. So we run this goes through the integrated governance steering group, or through the information governance steering group. Sorry, we run an audit of access throughout the year. So over the last number of years, clearly we have always turned up a few cases where people haven't got a legitimate relationship. As Natalie says, it does depend on the circumstances, but we have in some cases dismissed staff, and in other ones taken a lesser sanction. It does exactly depend on the circumstances, but there is a full auditing process. Actually, it triggers up when people have not got a legitimate relationship. So we look into that. Jill might add a little bit more, but there's a whole safeguards and controls we have around this that's picked up through the information governance steering group.
Thank you, Robert. I think Jill was concurring with your view and has taken her hand down. So thank you for that clarification.
Sorry, Mark. There's just one other thing, and we have on occasion, we have historically reported such breaches to the Information Commissioner's Office, because it is also potentially a criminal offence to access that sort of information. Just going back to the original question, I think the view has been taken previously that this is potentially an act of gross misconduct that may, depending upon the mitigations, be brought down from gross misconduct to some other sanction.
Thank you. Sounds like I certainly received assurance there that we are dealing with these things appropriately and proportionately, which is what we always look for. Tessa.
If I can just make a comment on that last conversation and then say what I was going to say originally. Do our systems and processes block the access? So are our systems robust enough to say, actually, you haven't got a right to see this, or are we locking the stable door after the horse has bolted?
I think Jill looks like she's going to respond to that. So Jill.
So if you don't have a legitimate relationship with the patient, so if, for example, I access care notes, I have to give a reason as to why I am accessing that record. So I have to put a commentary on there, and we do audits to look at that and then to see as to whether, for example, the commentary that's provided is supported by evidence.
Thanks, Jill. And the other thing I just wanted to say was, I should have said this when I was doing the update. The other big piece of work is that Vina has taken over as the non-executive director lead for Freedom to Speak Up, and again has been meeting regularly with myself and Natasha to make a smooth handover.
Thank you, Tessa. And on that previous one, with regard to access, Lisa, I presume this is all taken into account in our new super new, improved and easy to use EPR record when it comes online, 15 months from now. That'll be a consideration in that, I guess.
It is, Mark, yeah.
Thank you very much. Beej and then Sue. Beej.
Thanks, Mark. Very quickly, Jill, you're probably the one to ask this question. And I just wondered, to what extent, on that former point, to what extent the organisation faces any liability or sanction if records are being used inappropriately by staff members, from a GDPR perspective or otherwise?
So we have had a small number of claims relating to breach of our data protection principles, actually not in regard of individuals accessing inappropriately. It's tended to be where there's been a legitimate access, but information has been shared inappropriately. So yes, there is a potential claim, a civil claim for which we are liable. And we have had a small number of data protection claims. We are insured for those. Obviously, I think the most important thing from my perspective is that the public have confidence in how we use data and keep it safe. And we maintain an awful lot of very personal, sensitive data. And so it's really important that both our staff and patients have confidence that we're managing that properly.
And finally, Sue.
Well, just to close that one, presumably we could also be fined by the ICO if we were not doing things properly. But just on a completely different thing, I was really gratified to learn that we have some nursing associate apprentices who have been nominated for potential Learner of the Year awards. That's really, really good, and congratulations to all involved in that.
Thank you, Sue. I think your comments are well made. On my various visits, I bump into nursing associates that are going through our development process, and there are no bigger smiles on staff faces than those that are going through that process, where they're achieving what is often their life ambition to become a registered nurse, and we're assisting them to do that. So it's great if any of those can receive accolades. Okay, can we note the workforce report? Thank you, and move on to Beej, Finance and Performance Committee.
Thank you. I think the report is there for everybody to see. It's fairly clear, and I'm taking it as read. The things I'd like to draw out, I think, in respect of the sections that we talked about for assurance, I think it's fair to say we had a colourful and interesting debate around agency spend, and of course, it's a topic that's come up in workforce from a workforce related perspective. So that was assurance level 5, and I think we're comfortable at that level, but all eyes are on that and we're watching that very carefully. I think in terms of the areas that we discussed where we made decisions, and the committee authorised 3 areas, that all those 3 areas are being heard at board today. That's the performance management framework, revenue capital budgets, and of course the EPR. So confident that the rest of the board will have a chance to debate those today. I think more generally, I'd like to make the point that the finance team have continued to do an excellent job, and organisationally, I think we're doing an excellent job in respect to the numbers. Q4 projected deliveries as planned, and month 10 was 2.4 million surplus, which is great. I think the assurance that we need to have as a board, and I think for the public record as well, is that the financial prudence that we as an organisation have shown historically and continue to show right now doesn't come at the expense of anything else. And importantly, that when plans are formed by the organisation, there's three key pillars, and that is quality of service for our patients, that is operational performance and operational efficiency, and importantly, financial sustainability. And it's our role as the board to make sure that there's a balance when it comes to those three things. So I feel confident that's exactly what's happening when we look at those and govern those. The final bit I'll say is around the trust business planning. I think it's been mentioned already by a number of people, yourself as well, Mark, that the delay in the national planning guidance is particularly unhelpful. And of course, that has meant that when we're talking about business planning, it becomes incredibly difficult. And Sue and the team have done a great job so far, but that is a work in progress. And finally, the committee said goodbye to Tessa and thanked her quite rightly for the immense service that she's given the committee. And I'll do that again as part of the board now. Thank you, Tessa.
Okay, anything else to add
Robert,
there?
did you want to add anything? Have I missed anything, Robert?
Can I ask, this has been from my ignorance, and I'm looking at the section 3 of our oversight metrics, and in my head, the assurance level of 2 around children, young people and access to services is sort of a bit incongruent with what I read. This is mental health, with what we read about waiting times in a previous report. I'll try to give you a page now. It's 7 of 10 of the performance report. Matthew, I don't know if you could.
Yes, so the national target is around the numbers of children who access, not the length of time they wait for. So in the Herefordshire and Worcestershire system, we are below our access target. Our belief is that part of that is because other systems have found ways of capturing data around access in schools where group interventions are recorded, but we haven't yet. We've got some ideas, but we haven't yet signed off a way to capture that data as well within our CAMS services.
Okay, that explains it. You'll understand when I see a glowing red, it sort of draws the eye to try and understand what it's about. But that's a good explanation, and thank you, Matthew. Is there anything else on any of that suite of financial reports or performance reports from Robert or Beach? No. Oh, sorry, Matthew.
Just to come back, Mark, to a question you raised at the beginning, which was about the changing targets for NHS talking therapies. So we've achieved. We have some guidance about how a new target will be collected, but not about what the target actually is. We have information that about the denominator, which is about people accessing treatment, which previously was about people accessing the services and having an assessment. When we've returned the performance planning template, because it doesn't yet have a target, we've had to work forward and set ourselves what we think would be a reasonable expectation of growth in line with the growth of our previous access target. So we've had to interpolate a little on that. So when I said that national guidance was unavailable, we haven't got national guidance in terms of what is your target for next year. So we've had our best guess what will be our activity for next year.
Okay, thank you. Outside of our gift, but doing as best we can, I think that says, which is good. Thank you, Matthew. If there's nothing else on those, can we note those suites report, and thank you to all behind them for the work, and move on to Martin and the Audit Committee. And if I could just ask Jill before Martin launches in, I can't see it in the report, or I've missed it, so my apologies, but are we also being asked to delegate, apart from noting it for assurance, are we being asked to delegate authority to sign off on the financial statement to the Audit Committee as well, are we?
Yes, and that's just an issue about the timing.
Okay, thank you. Martin.
Yes, so I'll be brief in relation to the Audit Committee. Firstly, I think it's again pointing out that the financial systems, payroll and treasury management has again received significant assurance. I know we get used to it, but it is no mean feat to do that year in, year out, and actually gives us confidence about the financial controls and systems in place within the trust that enables us to deliver the financial results that our team leads. So thank you for that. It also means that we can focus significant amounts of internal audit time on challenging areas where we point them towards areas that we know are problems in order to perhaps point the way forward. And some of those come through the Quality and Safety Committee, as Janet mentioned earlier, around medicines management or areas such as consent. And it's worth pointing out that the new annual work programme that we've developed for internal audit has been reviewed, and input has come from each of the committee chairs and their executive leads in designing that for next year. And we have a good programme developed associated with that. And finally, the final point I wanted to make is that we also carry out our annual review in January each year of the effectiveness of our internal and external audit services, and that review highlighted no significant issues other than one an improvement required in our counter fraud services, which has been taken on board, and we are addressing through work with our internal audit service. And then finally, as Mark suggested, we need approval for delegated authority for the Audit Committee to sign off the financial statements in due course when the time comes.
There's me thinking Jill was doing a good elephant impression. So that's the fifth time. So it's obviously a bad day for me for speaking on mute. Any questions at all on the Audit Committee report? In that case, can we agree to delegate authority to sign off the financial statements to the Audit Committee, please? There are nods all round. So Martin, yes, approval given. Thank you. Which takes us through to Sue. Charitable funds.
Yes, so in the report you'll see that we've done a little bit of spending, and we've also done a little bit of analysis of spending and where the bids come from, and we're glad to say that the bids are coming as much for staff projects as for patient projects, and that's something we'll carry on monitoring just to make sure that that stays as a balance. We talked a little bit about working out what an appropriate level of or balance of funds would be, so we're going to work that out for the next time. And we also talked about whether or not one role of the committee might be to do some awareness raising of the fact that we like to fundraise. So at the moment, we just rely really on our investment income going up with the stock market changes. But we don't actively fundraise. A sort of halfway house would be that when we do invest money in things like the garden projects at Primrose or the Dementia Garden, that we put a sign up to say who's funded it and maybe to encourage further funding. So that's something we're looking into going forward.
Okay, anybody got any questions there at all? No, okay, we can note that report. Thank you very much, and move on to Carol and the Joint Mental Health Collaborative Committee as it is now.
Indeed it is, and it's actually one where we need to make a decision today. So we finally got a terms of reference that have been run past lots of people on lots of occasions. They've been through several meetings of the Joint Committee, and previously of the Collaborative. I understand that they also went to the ICB board, the ICB yesterday, and they were agreed as well. So I think because we've been through that process, I would hope that we can sign these off today. We're going to see how it works and review them again in a year, because this is new territory for us, this way of working, and trying to see how we make it all function properly. So that would be my first request, that we can agree those. In terms of the other stuff that's in the plan, I think once we've got those terms of reference pinned down, nearly everything that we look at in terms of our target are the sorts of things that are included within our performance framework anyway. So I think what the Joint Committee will be focusing on are those things where it's a system level discussion that needs to take place rather than the conversations within the trust. So as well as receiving all the reports and the assurance through those, we'll also be looking at specific issues that we might want to just dig into a little bit more. And you'll see that we've already mentioned things like dementia diagnosis rate, because things are shifting by 0.5% or 1%. Clearly, they've been like that for so long. We just need to have a look at those, and also the sort of the issues that we know about around section 117. So those are the sorts of things we'll look at, and Martin will be pleased to hear this as well. I think the other bit, bearing in mind that Sarah Raystrick is the co-chair, who has also the Health and Equalities lead for the ICB, something that we would really like to be picking up in the future in terms of what's that broader picture around health inequalities, in particular in mental health. So we'll be looking at that. So I would expect us to have an action plan once we've got these terms of reference embedded, and then we'll start looking at the work that we pick up, as well as making any commissioning decisions and receiving all the performance report. Final thing, just on in future reports, the report might look slightly different because we've agreed to adopt the ICB format, which will be quite interesting for us to take on board. And also we will be including assurance levels once the discussions have been concluded about whether we use our levels or we use the ICB levels. So that's, again, groundbreaking stuff, and trying to pin that down. Sue, is there anything you wanted to add?
No, very comprehensive, as you say. Just seeing now the direction of travel and getting that Joint Committee status approved is really setting us off on a strong platform going forward.
Thank you, Carol. Martin, Carol mentioned the magic words.
I know.
Yeah, Carol set up my question beautifully, because I'm delighted that the Health Inequalities lead from a non-exec point of view is chairing the committee, but I don't see the exec lead for inequalities in that committee. And I know we're trying to move to a point of inequalities being everybody's business, but the danger is it becomes nobody's business. And we're not at that point yet where we absolutely can afford to sort of rely on everyone to bring up that inequalities point. So I think there's a gap there in that representation, but it might be covered in other ways.
Yeah.
And before Sue responds, as I think she will, can I just raise one thing on the terms of reference? They seem to suggest I'm not allowed to go. As chair of the trust that hosts it, that's what it says in the terms of reference. And I'm not being precious about things, but I would have expected me to be allowed to go on an ex officio basis as appropriate. But it makes it quite clear only members of the committee have the right to attend the meetings. However, this lot, etc. So I'm sure Carol or Sarah Raystrick wouldn't say, Mark, you're not allowed to go.
No, but yeah,
these terms of reference should probably be into a long time in the future, so perhaps that could be
we'll add that
considered.
Yeah, no, I don't see any problem with that. That's fine, thank you.
Thank you. Sue.
Yes, just to respond to Martin's query. So Martin, I'm an attendee at the committee, and obviously from our point of view in the board lead for health inequalities, from the ICB perspective, the health inequalities group that we've got across the system is chaired by Tanya Richardson. So she's both in public health and in the ICB with a lens on health inequalities. She currently comes to the Mental Health Collab Executive. So a lot of that challenge comes in there, which actually in terms of pathway redesign, sharing what we know about our populations and what we're transforming together, I think her input there is probably invaluable. Then it's the assurance that we really need to make sure we're rubber stamping in the committee that we're holding the executive to account in terms of shifting the dial in this space. I hope that's helpful.
Yeah, I think it's also quite powerful within those terms of reference that it allows us to ask for people to come and talk about any particular area. And I certainly would see that part of one of those items will be health inequalities. And Martin, even if your name's on the not on the list, I will let you in. So thank you very much.
Okay, thank you, Carol. Can we note that report? Thank you, colleagues. And then move on to Mental Health Legislation Committee.
Thank you, Mark. Just to say, this committee is unlike the other committees of the board in that it only meets 4 times a year, one of which is a training session. The purpose of the committee is to look at whether we are fulfilling the Mental Health Act requirements of the Trust as a mental health provider, and ensuring that patients get access to hearings and also access to advocacy, which we do on a regular basis. I think one of the things to note was that we were told that 2 hearings had been upheld and patients had been discharged. And one of the questions that the committee wanted to find out more about was, okay, what was that? What made that decision appropriate and possible for the associate hospital managers, and what can we learn from it, because it doesn't happen very often. So that's a piece of work that's being taken forward. And then finally, just to say that Sue is taking over from me as chair of this committee, and again Sue and I have met with Helen to ensure that there should be a smooth handover.
Thank you, Tessa. Any questions on that one at all? And of course, when I thanked you at the beginning, Tessa, I omitted to mention the Mental Health Legislation Committee, which was my error, because it's one of those committees that goes on in the background and does some great work, interesting work as well, important work. So thank you for all your activities on this, and I know it's being handed over to a safe pair of hands in Sue, so thank you very much. Which then leads on to the massive report that is the report on the Remuneration Committee, which is in my name. You'll understand, colleagues, that most, if not all, things that go to Remuneration Committee tend to have names against them, hence the brevity of the report. I ask you to accept it, and if anybody has any questions about anything that happens within that, I'm very happy to have a discussion, but the vast majority of it is obviously confidential to the individuals concerned. Can we note that report? Thank you very much. Matthew, EPRR core standards, you've discussed this previously with us, and actually the improvement that we've seen, dramatic improvement we've seen in the last 12 months, which is to you and your team's credit, but you have a specific ask for us today. My turn now. You're on mute, Matthew.
Yes, so the specific ask today is for the board to approve the assurance statement that will be published in the annual report, which is included in the EPRR final standards report attached.
And having all read it, are we happy to approve that? Okay, thank you. Nods all round. Approved. Thank you, Matthew. And again, it was reported, actually, there was a report that went to the ICB on this matter. And it's, again, a little bit like mental health legislation. Behind the scenes, this is all going on. And it's one of those things, it's an insurance policy, because we hope we don't have to use much of it. But when we do, we'll be really pleased it's there. So thank you to you and the team. Jill, reaffirming our Nolan principles, and hopefully we demonstrate them continually, but we are required to bring this to board. Is it 12 monthly?
Yes, and this is just reminding board members about the Nolan principles, obviously very important principles by which we need to both live and demonstrate, and also the standards expected in public life. So it's there just for a reminder for everybody and for us to reaffirm as we do. We've all recently signed our annual declarations for fit and proper person, and so this is just doing so in a public sphere.
Okay, everybody, I presume almost by default, by being here and by carrying out your roles, you support the Nolan principles, and just a reaffirmation, it's for us to model all these behaviours. So can we approve that, please? Yes, thank you, which takes us on to another fit and proper person. There has been some changes this year, hasn't there, Jill? So if you, although we're all aware of them.
Yes, so this is a refresh of the previous policy. The original fit and proper person policy regulation was passed in late 2014, and we've had policies in place since then. But in the autumn of 2023, NHS England issued a updated framework to provide additional clarification of what was included in the regulation. So the regulation talks about board members should be fit, and the NHS e-framework provides examples of things that the trust need to check to confirm such fitness. So things like people haven't been involved in for example, discriminatory conduct in employment tribunal proceedings and had judgments made against them. We are also going to be checking social media to check that people's use of social media is appropriate and not inconsistent with their roles. And these new areas are included in the policy. The updated guidance from NHS England also requires the data to be recorded on our electronic staff record, and updated privacy notices were shared with board members previously, and Mark is required as chair to make a submission to NHSE to confirm that we are following the framework, and this is included obviously in the updated policy. It's probably worth saying as well that our internal auditors are due to conduct an audit of our fit and proper person compliance in Q2, so that will be reported obviously to Audit Committee in due course. Happy to take any questions.
Anybody have any questions around that at all? Okay, and that's all already kicked in with some of the references we have to do, and we have to create the references for people. We'll have to do one for Sarah and Tessa, and they're kept to the age of 70, I believe, isn't it? So years yet. Right. Okay, thank you very much. If we could note all that and approve it. Sorry, we're looking for approval of that policy, which is a standard national policy adapted for us. Thank you very much. Nods all round. I'm unaware of any signatures or sealing of documents. That's item 31. It's disappointing again. There's been no advisory appointments committee for the appointment of consultants in this period. So sad to say we haven't got any of those to appoint. Any new items be included in the board assurance framework? Can anybody think of anything we may have missed? I do have one, which is not very thought through, so to speak, but it strikes me, and this is probably a conversation for Jill and I outside along with Robert / Sarah, our CQC action plan and the delivery of it in terms of represent not only reputation but the improvement of services to staff and patients. I'd like to think and believe that that's properly captured within the board assurance framework. I know it will be in various places, but I'm not sure that it's articulated correctly, because if I'm right, Jill, the board assurance framework should be about things that may stop us delivering or get in the way of delivering our strategic aims, and failure to act upon and deliver our improvement plan strikes me as something very at the very core of that. I don't know how to encapsulate it, but perhaps we can have conversations. Probably the easiest way to do it is if Scott and Jill have the conversations to start with, I guess. Am I thinking along the right lines there, Jill?
Yes, I can see, because we have reflected in the board assurance framework the impact on delivery of care and issues relating to attraction and retention of our workforce. But I think it's a fair challenge that we haven't got included in there the reputational impact of one, receiving the report, and two, the confidence of our staff, our patients, our partners in us making the necessary changes. So I think certainly happy to have conversations outside and think as to how we can articulate that.
Thank you very much. If nobody else has got anything, okay, that's the only one. Thank you. Date of the next meeting is 16th of May. And finally, thank you, Sarah. Thank you, Tess, for I said at the beginning. And good luck to Vina taking over Workforce Committee, Sue taking over Charitable Funds, and Mental Health Legislation Committee. I wish you well in that. I know you'll both do a fantastic job. And we will introduce to our next public board the interim chief executive and directors of finance next time it comes round, and we'll look forward to working with everybody. We are due to reconvene again at 1:30, colleagues, for a private session. We do have a commercially confidential item, and then board development, where we do have some guests coming at 2:30, I believe, Jill, is the correct timing for that. So thank you all for your forbearance with me and assisting me to manage the meeting to finish broadly on time. And I will see you all at 1:30. 1:30.